We are Group 3, and the topic chosen for this debate is it ethical to withhold artificial nutrition from those in a persistent vegetative state? I'm Nicole Kemker.
I'm Stacia Riley.
And we're presenting the viewpoint for the continuation of artificial nutrition and hydration in a patient in a persistent vegetative state.
And I'm Taylor Park.
And I'm Megan Powell.
And we're presenting for the pros of withholding artificial nutrition.
Before we get started with the debate, I want to define a few key terms that will be used throughout the discussion. First is pain, the physical feeling caused by disease, injury, or something that hurts the body. Second is persistent vegetative state, a condition in which a medical patient is completely unresponsive to psychological and physical stimuli and displays no sign of higher brain function, being kept alive only by medical intervention. The definition of artificial nutrition is any non-oral means of administering nutrition to a person. Methods encompass enteral and intravenous.
Okay, so on the side of the debate of continuing artificial nutrition, we have three main points. Those three main points are that it is making the body die, not letting it die. The second main point is that it is basic health care. And the third main point is thinking about the family and religious family that's involved and the religious beliefs that are involved.
Our first main point is that it's making the body die, not letting it die. So our first idea is that starvation and dehydration would cause pain. Persistent vegetative state actually spans across the continuum. Therefore, it's very difficult to determine one course of action for this type of patient. According to brainandspinalcord.org, there are varying degrees of consciousness, the strongest being patients who minimally respond to stimuli, and at the other end of the continuum, patients who have no ability to react to external stimuli.
The other point we have under that it's making the body die, not allowing the body to die, is that most PVS patients are in hospitals. And we actually found a survey of survivors of those individuals that stated that the patients that were in clinical settings experienced more pain than if they were at their home. So they may not have a sense of pain, but the body responds by the mouth getting dry, their muscles are twitching and spasming, and they may experience some vomiting.
Going along with the idea that it's making the body die and not letting it die is this idea that it could actually be considered euthanasia. Euthanasia, it could be considered this way because you're taking away food and water with the intent to cause death, hasten death. The term euthanasia refers to actions or omissions that result in the death of a person who was already gravely ill. And that was actually defined by a PhD, Dr. Jonathan Moreno.
And along that same lines, there may be a slippery slope between euthanasia and murder. Legalizing euthanasia or not providing an individual food and water can unfairly target the poor and the disabled, and it can also create incentives for insurance companies to withdraw care in order to save money.
As we stated before, our second main point for the continuation of artificial nutrition and hydration is that it's basic health care. So until providing nutrition becomes a tremendous burden or is considered futile, it should be continued. When actually doing some research, it's a relatively inexpensive medical intervention. The average cost is actually $8 per day. Some of the most popular artificial nutrition that's out there is actually Ensure, which can be purchased in a local grocery store. So we looked at the label of an Ensure bottle and found that there are a lot of nutritional benefits by using this. You know, it provides you with proteins, carbohydrates, sugars, fats, everything that the body would need for balanced nutrition. Each bottle of the #1 doctor recommended brand Ensure is a source of complete balanced nutrition. Every ready-to-drink shake is packed with 24 essential vitamins and minerals, including antioxidants. So if it's a quick meal for you and me, how can it actually be considered an extraordinary medical treatment when it's placed in a feeding tube and is that easy access?
And our second support of that it is considered basic health care is that food and water are considered medical interventions. Medical interventions are defined as any measure whose purpose is to improve health. And we would argue that PVS patients are entitled to basic health care, which includes nutrition, hydration, cleanliness, and warmth. Treatment that would, and also treatment that would prevent any type of infection or anything. But treatment should be distinguished from basic health care such as feeding, bathing, and preventing infections.
So according to the Practice Parameters Assessment and Management of Patients in the Persistent Vegetative State, which was published by the American Academy of Neurology, physicians and the family must determine appropriate levels of treatment relative to the administration or withdrawal of medications, supplemental oxygen, and the use of antibiotics, complex organ-sustaining treatments such as dialysis, administration of blood products, and artificial hydration and nutrition. That was actually listed by, the basic interventions that are given to people in a persistent vegetative state. Therefore, the idea of providing artificial nutrition and hydration should not be dismissed as a standard of care, as it's ranked as a necessary medical intervention, right along with medications, oxygen, and blood. The American Academy of Neurologists develops practice parameters for neurologists, and that American Academy deems artificial hydration and nutrition as being very important.
And under our third main point of taking into consideration the feelings and emotions and the situation of the families involved, in addition to the religious beliefs of the patient, we must consider the guilt and stress of the family members that would be making the decision to withhold nutrition. Family members often feel helpless in these situations, and as long as the benefits still outweigh the burden, there's no reason not to provide the nutrition and hydration to the patient. It is natural to associate the provision of food and water as an essential sign of our love and concern. Thus, it can be very difficult when families or even the patients themselves hear physicians suggest that artificial nutrition and hydration should be stopped.
Along with this main point of families and religion, as we said, a religious affiliation might actually call for the continuation of artificial nutrition and hydration. The religion of Judaism states that a person's life belongs to God, and therefore deciding when it ends should be left to God. Doctors and caregivers should not do anything to hasten death and generally must work to keep people alive as long as possible. Another religion that believes in this continuation is Buddhism. Buddhists are taught to have a great respect for life, even if that life is not being lived in optimal physical and mental health. And then the third religion that I'll be discussing is Catholicism. And their idea is that we don't have the authority to take into our hands when life will end. They're actually in favor of better palliative care. The natural law in the Fifth Commandment requires that all ordinary means must be used to preserve life, such as food, water, exercise, and medical care. As long as the body is able to process food and water, those things should be given.
In regards to pain in the patient, we should consider, how do you actually measure pain? And would you use the difference in vital signs to determine if the patient was actually experiencing pain? It's very hard to make that measurement when they're in a persistent vegetative state. If they are in pain, it's especially in a hospital setting, they have access to pain medication, which is in the normal scope of patient care, and technically they would have access to that at home as well. In regards to basic health care, there are other factors to consider, such as if the patient has insurance, or if they are poverty stricken, where for a family $8 a day may be considered a lot of money. The cost of an in-home nurse or a healthcare facility for a patient to be living at is also an extreme cost that should be considered for the family.
And then in regards to the family and religious views, there's a lot of different religions and beliefs that can coincide with like withholding or administering artificial nutrition. So it's kind of hard to say that and some have different beliefs entirely. So it's kind of hard to pick some sides that like support like some like religious beliefs that like you also believe in to like, kind of support you, while others say it's okay to withhold. So it's kind of hard, and it's just like kind of important to like take that in consideration with the personal like independent patient, because you have to cater to them and their beliefs. So it's kind of hard to generalize everything in the statement of religion. But that goes into our first point, which is the patient has the right to refuse medical treatment. And then in law, when patients, like in a normal case, when patients are competent to consent to treatment, they also have the right to refuse. And that's going to the court that they have the capacity to understand and retain information and weigh it in balance in order to arrive at like a logical decision. But this is a different case in persistent vegetative patients, where a lot of times they don't have an advance directive. So it's kind of hard to, it's impossible to really understand what the patient's beliefs are. So it kind of falls into the duty of the doctor to act in the patient's best interest and also with their family. But however, it's widely agreed that it is not in the patient's best interest to be subjected to a treatment which is futile. That is, it has no reasonable hope of therapeutic benefit. And then one of the examples that kind of like puts into perspective, it's not the exact same, is when a person is dying and their CPR is being performed on them, and at a certain point it becomes futile, and you wouldn't continue to do CPR because there's no chance to like bring them back. It'd just be like adding more harm to them. Another example that can be kind of viewed in the same light is patients that are in like the final stages of cancer and they're doing chemotherapy treatment. They, at a certain point, they start to weigh the burdens of like the treatment and the quality of life. So a lot of times with like the doctors and the patients and family involved, they'll decide if like continuing like the harsh chemotherapy treatment that could make their lives longer, or would they stop it to like avoid all that extra harm given to them, even though it would shorten their lifespan. It's kind of the same idea, but like it's different in the fact that they have their physical consent, whereas the people in the persistent vegetative state don't really have their own say. So it's different and the same all in one. But our second point is for that it won't reverse the current state of the patient. By administering this nutrition, it's kind of more of an act of like what like the family wants, kind of like to like make themselves feel, because they want their family to live as much, because like they're part of the family and everything. And but having the act of like giving artificial nutrition won't make the patient any better. It's just a means of sustaining life, but they won't have regained function in much way.
Our second main point is those in a persistent vegetative state can't experience pain. With this, we've already discussed this a little bit, but by moistening the lips, you can use lip balm, you can use ice chips. Those are all necessary. That's all that is needed to keep them comfortable. Our second subpoint is the oral intake of fluids during the dying decreases during the dying process. Water deprivation increases the body's production of endogenous opioids that create a euphoric state and has been associated with a reduction in pain. There's a comprehensive study of nursing home patients with dementia reported that the insertion of feeding tubes did not improve survival over those who were hand-fed. It did not lower the risk of aspiration pneumonia and did not improve pressure ulcer healings, weight status, comfort, or functional status. Another study found that nursing home residents with a feeding tube died 1.44 times sooner than those without a feeding tube.
And then our final point is the cost of nutrition support and the emotional and physical burden of caregivers must be considered when going into this. You guys briefly mentioned that the average cost for artificial nutrition is about $8 a day, but that adds up to about just under $3,000 a year, and that must be considered when going to these patients, because also you have to take in fact if they're in the hospital, there's the hospital care, or if they're in a healthcare facility, those can be very pricey, sometimes $5,000 to $7,000 a month, which, depending on the insurance, could be really burdensome for the family that's taking care of them. That they could live months to years after the start of artificial nutrition, so that adds up a lot over time. And another aspect is the emotional state that the caregivers have, because a lot of times the people that fall responsible for taking care of these people, sometimes they have to stop their jobs in order to give full care because they want to give care, or they can't afford a home health nurse if they're in the home setting. And it's just really hard because they are not as they don't have a medical knowledge of like what the best is. They just want to have their family live as long as possible. So it's kind of hard to really take into account the emotional state and like damage it's taking upon them.
Okay, so with regard to your first main point of the right to refuse, and you talked about how it's not necessarily part of routine care and that it won't reverse the individual's situation. It's a matter of belief there. Some do believe that is considered part of routine care and basic health care. And that's something we talked about initially, that basic health care includes food and nutrition. So that's more of a personal belief situation with regard to the routine care and it not reversing the situation.
Also, with this point, that the patient has a right to refuse and decide if they do or don't want care. Well, really, unless an advance directive is established, the patient cannot themselves decide that they do or do not want care. Statistics show that, most people don't actually have advance directives established, and it would fall kind of on the doctor's duty. However, if you do have a surrogate or someone making decisions for that patient, the actual duty is with that surrogate or the caregiver as opposed to the doctor's duty.
And with regard to your second main point of those in a persistent vegetative state can't experience pain, as we talked about in our initial opening arguments, that there's a continuum of PVS. There are some that can feel and experience mild stimuli. So for those who can, who's to say that they can't experience some type of pain?
Also, with this idea that they can't experience pain, whenever the body is deprived of water and food, there are physical symptoms that the body does go through. Without water, then the body gets dehydrated. Some physical symptoms of dehydration would be tachypnea, tachycardia, and low blood pressure. So those are some things that the patient would experience if they're just, getting lip balm and lotion applied.
And then with regard to your final main point of the cost and the emotional burden on caregivers, something you mentioned was of weighing the benefit and that the chance of the person not improving. So therefore your argument was to go ahead and take away the nutrition and the hydration. But if you think of a comparison of somebody who maybe has become a paraplegic because of an accident that they've been in, they will forever be in a wheelchair, but are you not going to provide them services so that they can live life to their fullest? The ability for people to live their lives depends on their particular situation. Mm-hmm. So yeah.
Also, to go along with this cost point, is that this cost is kind of minimal in comparison to the average cost of a completely healthy person. So for this person who is within a family, obviously someone who goes into a persistent vegetative state, it's not necessarily a planned thing. The cost of this person, if they were in a healthy condition, is factored into the family's daily life. So this cost is actually pretty minimal in compared to what a healthy person's cost is. So how can you actually put a dollar amount on your loved one's life? I mean, how do you make that decision? Okay.
So now we're going to present our secondary points to you all, and we did those under our main three points that we discussed earlier. And as a reminder, it's making the body die, not letting it die. That it is considered basic health care, and that you taking into account the family situation and the religious affiliation of the individual.
So one more point to make with our main point number 1 is that it's making the body die, not letting the body die. We formulated a patient scenario which kind of proves that the proximate cause of death would be the withholding of the artificial nutrition and hydration, and not the initial illness, essentially the persistent vegetative state, which is actually causing the patient to die. So take, for example, a patient who has come to be in a persistent vegetative state as a result of suffering head trauma from a motor vehicle accident. Other injuries from the accident include a broken rib, a sprained wrist, and some moderate bruising, but nothing critical. The patient, according to the term PVS, as defined by brainandspinalcord.org, the patient is still able to blink, experience sleep-wake cycles, breathe on their own, cry, although not from external stimuli. They have normal circulation, and they smile. Their lower brainstem is still healthy and fully functioning. So for this patient, removing artificial nutrition and hydration would be the primary cause of death. Their brain injury, also known as their initial illness, would not be the cause of the patient's death.
And under our second point of that, providing nutrition and hydration is considered basic health care. Doing so has been around for many, many, many years. And after researching the history of artificial nutrition, we found that it dates back over 3,500 years. So some examples include that the ancient Greeks and Egyptians used rectal feedings to preserve health. During the 12th century, the upper GI tract was used to insert nutrition into the esophagus. In the 17th century, that brought the beginning of TPN. The 19th century brought surgically placed feeding tubes, and the 20th century brought the PEG tube.
And just to close up our side for the continuation of artificial nutrition hydration is our main point number 3, family and religion. This is actually, it can be considered disturbing for the family to watch essentially their loved ones starving to death. And we need to keep in mind that our job as caregivers is to always maintain the patient's dignity. So a family must watch their loved one regress from the time that the artificial nutrition and hydration is removed until they actually die. This can take anywhere from 3 days to 14 days to even upwards of 25 days and more. And that regression is a direct result of the decision that they made, which would ultimately end in their loved one's demise. So you can imagine how tough of a decision that might be and what kind of burden that might place on the family who is there to watch it all.
And that'll take us to kind of our last points for last section of all of our 3 points. And to go with the patient has the right to refuse medical treatment. Our last thing is that it's a medical treatment intervention is not simply a part of ordinary routine care for all patients. And that's kind of a different varying opinions, kind of personal, but also states have different viewpoints. And one of the cases I found was it's called Trust versus Bland case, and in the end the doctor and the family kind of agreed to withhold treatment, but the person taking the place of the patient, who was his surrogate, was saying that it was murder, but in the end they stated that the doctor was under no obligation to continue his treatment because it was not in Mr. Bland's best interest and because it was futile. So that it's a very specific case because the family was on board with the doctors, but the person representing the patient who didn't have the ability to talk and he had no living will, he was fighting to keep him alive. So it's all very different in case by case, but in this case this ruling did say that it's to give this treatment is not part of the ordinary care, so thus they could omit giving it to them.
So our second main point was those in a persistent vegetative state can't experience pain. Our last subpoint to go along with that is that the provision of intravenous hydration can actually have a negative impact on their quality of life because it increases pulmonary secretions, urinary output, nausea, vomiting, and edema. As stated previously, the symptoms of dry mouth, they can be managed with ice chips, lip balm, and moistened swabs.
And then for a third point, the cost of nutritional support and the emotional and physical burden of caregivers must be considered. Is that regardless of what you choose, the patient's condition will continue to worsen because they're in a persistent vegetative state. Like they have no chance of like improving their function from where it's at. So at some point in time, they're going to decrease no matter what action you take. So it's just like weighing the cost of extending the life and like the chance of like decreasing the quality of life and their burden, or stopping it sooner to essentially end their suffering. But that just goes into the viewpoint of who's taking care of them.
All right, we are going to end with a concluding statement. Nutritional support at the end of life or when a patient is in a persistent vegetative state is a difficult situation that should be carefully examined. The patient's wishes, prognosis, and therapy goals should all be considered. Open and honest communication among the patient, their family, and the healthcare team is essential to the best outcome. Ongoing evaluation of benefit versus burden should occur throughout the therapy. Regardless if you are on the side of allowing artificial nutrition or withholding it, most importantly it is to consider the patient's autonomy in making informed decisions regarding the patient and whether nutritional support should be withheld or not for a patient in a persistent vegetative state.